Every time a new AI model drops, we get two things: a flurry of academic papers and a parade of hype men screaming, "Doctors are done for, the machines are here." Well, before we throw away our stats, let's take a step back and actually think about it. Are these claims even real? And are these AI models actually good at medicine, or are they just good at passing tests? Well, here's the thing. You could ask a language model to write you a poem about a pink giraffe with cystic fibrosis sitting on a moon, and it will give you a different poem every single time, which is great for creativity, but not so great for reproducible medical advice. And comparing these single answers that change on every input make these test results basically a matter of chance. So, what do we do instead? Well, that is where benchmarks come in. Think of it like the toy that we have all played with in our childhood, and I actually had to Google the name of it. It's called a Galton board. So, when you throw a single ball from the top and it bounces left and right and through the pegs, where does it actually land? Well, it is impossible to predict for one ball. But if you drop 100 balls from the top, a clear pattern starts to emerge at the bottom, which is a bell curve. And benchmarks work in a similar way. A single model response might be random, but when you ask the same type of question hundred of times, you start to see the performance trend of that model. So now that we understand what are benchmarks, let's understand what are the types of benchmarks. And for the scope of this video, let's say there are two types. First, these test whether the answers of the models are right or wrong, like MedQA, MCQA. These test the models on multiple questions which have an objective right or wrong answer. And then there's the second type where there isn't always an objectively correct answer. Let's take HealthBench for example. It's an open source benchmark by OpenAI that evaluates models in a simulated doctor-patient setting. The user plays the role of the patient and asks questions, and the model responds like how a doctor would. And then another model, GPT 4.1 actually, compares the response to how a real clinician responded according to its data set, and then assigns a score to it based on how close the response was. And in my opinion, the scores of tests like the second one are far more relevant than the first. Well, because real patients aren't multiple choice questions. They ramble, they change their stories, and the model needs to keep up with that. Ask the right questions and be able to actually think. But wait, before you close this video and start searching on Google, what is the top AI model on HealthBench? There's a catch. These models can be optimized to ace these benchmarks. Think of these benchmarks like electrons. They are valid as long as they are unobserved. But the moment they are published and AI companies start to take note of them, they start tailoring their models to score well on that particular task. And that's not always the same thing as being useful in real practice. To quote a more relatable example, remember your med school topper, the one who could recite every single line from the Harrison? Well, they always topped exams because they were overtrained on textbook questions. But when it came to the real patient, they struggled. Why? Because real cases need more than just memorization. You need things like history taking, being able to build patient rapport, good judgment ability, the ability to adapt. And that is exactly what happens with AI models. These models are overfitted and they become great at benchmarks because they've been basically tuned to ace the test. But in practice, where the goal is to treat the patient, they often fall short. So remember, just because a model comes swinging with a fancy benchmark graph, it does not mean it's ready for your emergency room. Benchmarks can be gamed, and in capitalism, bigger bar graphs mean bigger bragging rights, and sometimes, and unfortunately, it's the only thing that is getting bigger. So what does this all mean for you as a doctor? Rule of thumb, newer models will always perform better than the previous one, but do not take that as a gospel truth. Set up your own mini benchmarks. How? Well, try the model on your own use case, like give it the chief complaint of eye spots and see if it can ask smart follow-up questions and actually lead to a diagnosis of a migraine. This method might not be peer reviewed, might not be perfect, but at least it is relevant to the work that you would be doing. So to conclude, benchmarks are helpful, they set a bar and they do track progress. But real medicine does not always happen on a leaderboard, and the best AI models aren't always the one with the tallest graph. So test these models yourself and use them as tools. And whenever in doubt, trust your clinical gut.